Yeah, that's correct.
Okay, there I am. Can you hear me now, I guess?
And if you record on the computer, though, you'll have to share it, send it back later.
You'll have to, yeah, you can send it.
Sure. Okay, well, thank you very much for inviting me. Yeah, my name is Sanders Burstein. I'm a retired physician. I was in primary care and geriatrics in New Hampshire since 1984. I was a medical director for Dartmouth-Hitchcock in Nashua and was part of their Honoring Care Decisions Advanced Care Planning Program and leadership education. And since retirement, I've done some work for Respecting Choices, which I'll talk a little about, and I've done some leadership coaching across New Hampshire. And I've talked on this topic, I'll tell you, at least 50 times to a number of different audiences, including the Bar Association, Medical Association, hospital groups, financial planners, nurses, many times. And I recognize this is a varied group, and many of you may know a lot of this, but I'm hoping you get some new insights and experience this in a new way. So let's see if I can move this along. Yeah, so the objectives of what I'm going to do is, first, we're going to understand, we hope that you'll understand the purpose of the advanced directive, that you understand the importance and evidence for good advanced care planning, that you appreciate that the advanced care planning is only as good as a system of care to promote and improve that process. And then I'd like to give us a chance to experience this in a group setting. So I understand this is an engaging group, that people are happy to speak up, but I'd like to sort of wake us up a little bit to that this morning by getting you to do some talking at first. So I'm going to start off with a little bit of a quiz. So, and I can't see everybody for some reason or other. I don't have a gallery. Oh, maybe I have a gallery view now. It's not very big gallery view. Does anyone know what happened on May 3rd, 2003? And I only see 6 of us. If anyone knows what happened, could you unmute yourself and tell me? I'll give you a hint. This more appropriately would have happened in the fall. So this is New Hampshire history. Okay, so the old man in the mountain fell.
Oh.
Okay, now you know. So now here's another piece of New Hampshire history. Who said live free or die?
Oh.
Does anyone know?
I know that.
Someone want to
Shoot.
shout it out?
Franklin Pierce?
No, Franklin. Well, he might have said it, but he was not the one to say it. No.
General Stark?
General Stark. Yes, who was General Stark? Who was General John Stark? He led the Battle of Bennington, which was by a turning point in the Revolutionary War. And he wrote that in a letter. He was being honored for his role at a dinner, and he couldn't make the dinner, so he wrote a letter. And in the letter, he wrote, live free or die. But here's the next question. What was the rest of the quote? He said, live free or die. Does anyone know? Someone tells me this is at the top of the Union leader. So it's live free or die. Death is not the worst of evils.
Oh, I've heard of that.
So let me ask you, what is the worst of evils? So we could talk about that for hours, and there'd be much debate, especially these days. But I heard Ira Byock once say that the worst of evils might be watching someone you know suffer and then die, and then realizing afterwards that it wasn't necessary. So that could be the worst of evils. So here's the rest of the quiz. Most people die as a result of sudden death from an acute medical event, from a traumatic event, or chronic progressive illness. Now, for some reason or other, I can't see everybody's hand here. So think about the answer. I was hoping to see a raise of hands. How many people think number 1? Number 2? Number 3? So, yes, most people die from a chronic illness, not from something sudden. So what percentage of people would rather die at home surrounded by loved ones? A, B, C, D? Most people would rather die at home. And what percentage of deaths occur in a medical institution? When I say that, I mean a hospital or a long-term care facility. So most people die in a medical institution. And what percentage of people surveyed in the US have an advance directive available? Think about the answer. So 26%. New Hampshire, it's about 30%. The Foundation for Healthy Communities does a survey every year, and it hovers around that based on a survey of hospitals, inpatients at hospitals. And what percentage of people are not capable of making their own decisions on their own behalf at the end of life? That's about half of the people are not able, someone has to make decisions for them. And everybody wants to go to heaven, but nobody wants to hear a boring lecture or pay taxes or die. Which one?
C.
Nobody wants any of that. But the only prerequisite for going to heaven is dying, I'm afraid to say. So just want to clear up the language first. Many people talk about advanced directives or advanced care planning. And I just want to make sure that people understand that it's advanced directives, which assigns healthcare decision-making in advance. So it's not advanced directives, it's not advanced care planning. It is advanced illness management. If you heard of AIM, that's for people whose illness is advanced. But otherwise, care planning directives are made in advance. So really what I'm going to talk about is about decision-making. Oh, someone wants to come in. Sheila. Sorry. Welcome, Sheila. Sorry, I just noticed you wanted to be admitted. So it's really about decision-making, and that's what really is the thing most interesting to me about this topic. And the way we make decisions has changed over the years. In the old days, what we called shared decision-making is when the doctor would share the decision with the patient. In fact, the medical ethics of the Medical Society back in the 60s suggested that doctors shouldn't share bad information with their patients if it was going to cause them undue stress. Of course, that's changed quite a bit. And in fact, it became law with the Patient Self-Determination Act. It was passed in 1990 and enacted in 1991. And with that, patients were given the right to accept or refuse care and to create an advance directive. And so decision-making went from the doctors making decisions to what we call informed consent. And that's where doctors present the risks and the benefits of your choices, the risks of your choice to do something or not to do something or do it one way or another, and the benefits and the risks, and lay it out for patients in the best way they can. They can't really present all the information that they have or all the experience they have. They present it in a way that they think will give people the best way to make their decision. But it's really limited because they can present information in a way that without consciously doing this, they can present information in a biased way, presenting the risks and the benefits. And often patients say, "Doc, what do you want me to do? What do you think I should do?" So that's the standard way since the Patient Self-Determination Act. But really the best practice is what we call shared decision-making, not the kind where the doctor shares the decision, but where patients and doctors inform each other in order to make the best choice amongst reasonable alternatives. You don't have to have shared decision-making for all decisions. It's really when it's a decision that has very significant consequences, or when there are two equally acceptable alternatives, whether it's, let's say, for treating cancer, and the outcomes are the same for radiation or surgery or chemo. So if the alternative, amongst reasonable choices, two experts come to the decision. The patient is an expert about what they value, what their goals are, what they want to do, what's important to them. And the doctor is an expert, or a nurse practitioner, an expert in the medical evidence. And so the two of them come together, and the patient shares, the doctor has an understanding of what is important to the patient and can help guide the patient to make the decision that will help them reach their goal based on the medical evidence. Any questions about shared decision-making? And I can't see everybody, so I can't see your hands. So if someone wants to just shout out, otherwise I'll continue. Okay, so this is really about shared decision-making. But it's also about New Hampshire law. And I recognize there's some people here from Maine, and I will mention something about the Maine Advance Directive. But this is in Title 10, Chapter 137J, written directives for making medical decisions for adults without capacity to make healthcare decisions. So there are over 30 sections to this statute. But the basic purpose of that is to declare that the laws of the state shall recognize the right of a competent person to make a written directive, which delegates authority to make healthcare decisions when that person loses the ability to make decisions for themselves. And also to instruct their attending physician to withhold or withdraw life-sustaining treatment in the event that that person is near death or permanently unconscious. So that's the purpose of this law. And the other sections in it go into more detail about the rights and responsibilities, the role of the physician in determining decision-making capacity, the laws around how to sign it, how to notarize it, or how to witness it, who can and who cannot be agents. I'll go into a little bit of that later on when it comes to common errors that happen with advance directives. So there's 3 sections to the advance directive. By New Hampshire law, there has to be a disclosure statement in the advance directive. And that's written out in the law. And for those of you that have a copy of the Advanced Care Planning Guide from the Foundation for Healthy Communities, which we sent out ahead of time, that's somewhere on page 5 or 6. And the advance directive has to be basically in a similar form to the law. So the one that's put out by Foundation for Healthy Communities is based on the law and includes a disclosure statement, the section on the durable power of attorney for healthcare, and a section on the living will. And this is what the New Hampshire Advanced Care Planning Guide looks like. There are other similar ones out there. The Catholic Church has one that's consistent with this, with additional guidelines. And when you go to an attorney's office for estate planning, because advanced care planning, advanced directives doesn't take the place of estate planning or general power of attorney or wills. So when you go, they may provide you with just the specific word verbatim from the law, but this is the guide that's most commonly used and given out by hospitals. Now, Maine has an advanced directive form, which I like very much, and there are several parts to it. And I know there's and I'm not going to go in detail on these, but I will say that what I understand from state law, and Joy, you can correct me on this if I'm wrong, but that in New Hampshire, as long as it's part of the policies of the institutions, advanced directives that are legally prepared in another state are honored here in New Hampshire, as long as it's consistent with New Hampshire law. So for example, if there's a state that has a death with dignity statute, and they had an advanced directive completed in that state, like Vermont or Oregon, we would recognize the agent who was legally signed by the directive prepared in another state, but not necessarily the laws of that state. So those of you that are in Maine, if an advanced directive is completed in Maine and it presents with the patient to a New Hampshire hospital, I understand that most hospitals will accept those as legally directing who the agent is.
Can I just say this though? But
Yeah.
I've had clients who go down and have surgery or something in Massachusetts, and the hospitals are like, we don't care, sign a new one here.
They do that, yes.
And which sometimes you're revoking your other healthcare powers of attorney, but nobody checks, but still it's a little annoying.
It is annoying. And in fact, the laws of those, and in fact, many of those hospitals will have in their policies and procedures that they will accept directives from other states, but people are just playing it safe and doing that. And if they're able to do that, I mean, that's possible if someone hasn't lost capacity. If someone's lost capacity and there's no guardian, then it's really the agent who has to make those decisions. So it'll be interesting to see what happens in those hospitals when someone comes down and they cross the border and they've lost that decision capacity. Anyway, so.
And can I just ask you really quickly? So
Yes.
I technically live in Maine. My house is in Maine, but I do everything in New Hampshire. Do I have to fill out Maine forms? These forms say New Hampshire. I can't use these. I would have to use Maine forms because my residence is Maine. Is that correct, or does it matter?
I don't think it really matters. It depends on if you're going to a New Hampshire hospital, you might want to check if they will honor a Maine directive. And you could get it filled out in New Hampshire. You just have to have the form witnessed by two people, state your address. But, and you might have both. I don't know that one negates the other.
Yeah, you just have to look at the documents and make sure it doesn't say I hereby revoke a prior healthcare power of attorney, because that's a lot of times if you sign one in New Hampshire, it says that you're revoking all your other prior healthcare powers of attorney. So that's where
I haven't seen that on the one that's in the one that I distributed, but you may want to check that out. But just completing was there another comment?
Well, I have had clients, though, if they do live in one state but work in another state or come to their doctors, they'll fill one out in each state, right? And then they'll just make sure the power of attorney doesn't say it revokes the other one. So
Right.
you can say, you can cross that out where it says I revoke my other ones. So
Right. Thank you. So just completing the advanced directive doesn't work. The prevalence is low. They're often unavailable. They're locked up someplace. People don't know where they are. They may be too vague. As a physician, I recall a number of times, I was the medical director of several nursing homes. And I recall on a number of occasions where someone would lose, someone had dementia, they lost capacity to make decisions. And I would call a nephew who was assigned in Connecticut. He had no idea that he was the agent. He didn't want anything to do with it. So, they may be ambiguous. There's no conversation. It's not understood, not supported. The prevalence is low. Doctors don't necessarily trust them. It just doesn't seem to work. So we say that advanced directives are only as good as the process of advanced care planning, which is really about conversations. So advanced care planning is planning in advance for future healthcare decisions. No other decisions, just healthcare decisions. If a sudden unexpected event were to happen, and many of the laws were based on sudden events of young people, people in their teens or 20s who lost capacity due to a car accident or a drug event, or if an expected complication of your known chronic illness. So many of us who are dealing with pathways to aging have patients who have known illnesses with a known trajectory and expected complications. So, and if that expected complication happened, left you unable to communicate, and other people would need to make decisions for you. That's advanced care planning. Someone else needs to be prepared to make your decision maker. And they may need to make decisions that don't even exist today because there'll be a new treatment, a new test, a new surgery. And so preparing others to make your decision making based on their knowledge of your goals and values. So really, advanced care planning is a process. And we describe that as a process of understanding what do you understand about your illness, about your choices, reflecting on your own experiences, what you learn from your experiences, what your goals and values are, what living well is, what your fears and concerns are, and then discussing the choices or discussing that and preparing your agent so that they could be your shared decision maker. Now, it's not one size fits all. So this is a trajectory of life. We reach our peak of health sometime around 30, and then it's all downhill from there. We know that our lung function, cardiac function, kidney function, everything declines. Along the way, we get sick, we bounce back, but we're never quite the same. And at some point, we all die. So there are conversations that could happen at different stages of life. We call it first steps when we're just assigning an agent for someone who's young. My children, I have 4 children that are over the age of 18, and they all gave me for my birthday one year their advanced directive. They're all well. Then there's next steps, which is people who are not necessarily at the end of life. They have a serious illness, but it helps prepare someone to understand your goals and values should an expected bad complication happen with your illness. Or last steps, or the POLST, as we call it, the physician or provider order for life-sustaining treatment. That's a specific document that is not part of New Hampshire law, but consistent with New Hampshire law, that is medical orders that is signed by a physician or nurse practitioner so that people, ambulances, and nursing homes, assisted living facilities can act on doctor's orders. And I'm just going to talk about advanced care planning in general today, but be happy to talk about these other topics at another time. So the benefits are, there's evidence that there are physical symptoms of depression. There's improvements in physical symptoms of depression. People that engage in this believe that their doctors understand their preferences and care more about them. Even if the doctor is not having the conversation, they sign that advanced care planning conversation to somebody else. We've trained nurses, social workers. We've even trained volunteers in churches and community groups to have these conversations. It helps prepare them for death better. And most importantly to me is it lessens the burden on loved ones. There's evidence that for at least 5 years after the death of a loved one, if someone makes a decision and they weren't confident of the decision because they hadn't had a conversation, that they suffer in some way. And it establishes basis for ongoing communication. And the discouraging news about all of this is that it's not done. Often this is done without a conversation. It's not available, it's not clear, it's not followed. It really comes down to there's no system for making sure this happens. And so what do I mean by a system? Well, I'll tell you first that It can be done because some of you may have heard of La Crosse, Wisconsin. It's a small city in the purple state of Wisconsin where 99% of people have advanced directives, or maybe 96% of people have advanced directives. And in La Crosse, Wisconsin, they want to be informed, they're receptive. If you were to go up, randomly go down the street and knock on doors, people have advanced directives. And if they don't, they're being pressured by their neighbors to have them. They're available, they're followed. There's evidence that their advanced directives are followed 99% of the time. It turns out to reduce readmissions to the hospital. There are improvements in population health metrics. In fact, the major health system, one of the major health systems in La Crosse, Wisconsin, the Gunderson Health System, they actually were at one point, and they don't like to boast about this because this is not the point of advanced care planning, but they were considered the most profitable hospital system in the country sometime in the last 10 years. And they say that they take those profits and put it into better advanced care planning. And to understand that, it could be that people that are in the ICU and in hospitals in La Crosse, Wisconsin are there. They're not there while families are trying to agonize over decisions. They're there because they need to be there, because they want to be there. So we say that advanced care planning is only good as a system that supports, promotes, and improves the process. And so some of the key elements of respecting choices is a program that was developed at Gunderson, and now it's part of CTAC, the Coalition to Transform Advanced Care. And they developed a systems approach, and they've done training with hospital systems, and it begins with leadership support. And that's oftentimes the weak link in this. And with leadership support comes designing a system so that people are identified, invited to advanced care planning, that there's good discussions by certified, trained facilitators who document people's choices and agents, that there's a plan for how to decide someone's lost capacity, where to find the document, and physicians.
No, they're not. I'll make it easy. They're not letting chaplain or social work in.
I'm sorry? Say that again? Okay. So, the other elements are there's community engagement and very importantly, continuous quality improvement. So systems that work on this measure the amount of times they invite people. They try to increase the odds that people will come to a conversation, increase the odds that people will have a conversation, that they'll complete the document, that they'll sign it, they'll have it witnessed, that it'll be available, that it's used, that doctors look for it, and that in the end, that their choices are honored. So that's a systems approach. And that's way beyond what we're going to go into today. And that involves many hours of discussion and planning, but hours that are well spent. So there's evidence from international studies on advanced care planning that hospital systems that engage in this have overall higher satisfaction with the health system, even when they're not being asked about the advanced care planning conversation. If there are advanced care planning conversations that are routine, there's overall higher satisfaction. There's evidence that healthcare agents are better able to predict patient choices after a good advanced care planning discussion. There's lower incidence of depression among surviving family members, and the cost of care at the end of life is lower in communities with good advanced care planning. So the key points to remember is that advanced care planning is planning in advance for healthcare, that the advanced directive assigns someone else to be the decision maker, hopefully a shared decision maker when healthcare decision-making capacity is lost, that it doesn't become active until the physician or nurse practitioner documents the loss of decision-making capacity. And that's a problem in itself because many physicians don't appreciate that role. It's only as good as the advanced care planning conversation. And a system approach to design workflows, certify facilitators, and engage the community can help assure a quality improvement approach to advanced care planning. And that effective advanced care planning can improve the quality, satisfaction, and cost of healthcare and provide comfort and confidence to patients and their families. So now I'm going to pause the recording of this if I can. I don't know how to do that. Stop recording.